and a Cuba.
Yeah.
Gabe Wagman, Dr. Gabe Wagman, cardiology. I do ER in hospitals. This is day 6. We just did 6 days in county hospital in Brooklyn. We missed the peak, but it's still in the middle of coronavirus.
Yeah. 3rd and 4th quarter time is what I would say.
I think there's going to be overtime. There's going to be
overtime
in this game.
It's definitely going to be an overtime game. Okay. Wow. They're coming back a little bit. All right.
We're old now, but I met that guy. We were roommates in medical school for a month. I'm gonna sit back and just want to explain to these people what's going on, give them a setting, and then we're gonna tell you what our experience about working in the hospital with sick people with coronavirus. And I'm kind of interested to hear, especially from you, like what you thought before and like then afterwards, how that's changed your opinion of things. But let me give them a little setup.
Sure.
We were roommates when I was in medical school in Kansas City and wanted to go to the big city, and I did an externship at Beth Israel in Manhattan, and they put me in a room with that guy.
But I got there first.
We don't need to tell the whole story.
Go ahead.
But we played sports and watched football and became buddies and have kept in touch. And we even went to Croatia last year.
Broadened.
And I don't know, I think it wasn't even a couple weeks ago when I was like, hey, I'm thinking about coming to New York. I'm like working in ERs in California and there's not a lot of corona, and I see just like shit's going down in New York. And I wanted to be here and be part of it and help out. And so I started mentioning that to you, and you happen to have vacation.
Yeah.
It's like the stars aligned.
Yeah.
And so we started to kind of apply to try the .gov website, and I don't even know how we found this one. Do you remember I think I got it from somebody and applied, and then once I got accepted, which wasn't too bad, I was just like, hey, Dr. Wagman's a good doctor too. You guys need to use him. And they're like, great, sounds good.
They just want all the help they can get.
They wanted help. And we ended up, it really worked out to where not only did we get to work together, but we were on the same floor. So the two of us were the attendings on one floor, or North, Kings County, for a week. And here we are, we're going to talk about it. Kind of what was it really like? The first question I have for you is like, because you work in New York, and so you treated a lot of this. Did this week working on these floors change what you thought Corona was? Was it like more of the same?
It was both. It was more the same and different in that it's the same disease, of course. But then in some of the hospitals that I was working at, they had a pretty defined protocol. And that protocol was significantly different from the one that they used at King's.
How so? Like what stuff?
I mean, some of the basic medications like hydroxychloroquine, azithromycin. So in the hospitals that I was working at just previously, they had a hard and fast protocol. They were giving hydroxychloroquine solo for new COVID admissions, but not in tandem with azithromycin, which is what they seem to do here in Kings County. If you're
so you guys don't do azithro?
There is azithro, no. So it seems like it's standard at Kings County, but azithro is not standard at the hospitals that I've worked
when I was going
Long Island.
When I was going to the ICU today, I think most of these guys don't think hydroxychloroquine does much.
I don't think anybody really thinks. I mean, no physician that I've spoken with thinks that.
I think before I did this week, I was like, oh, maybe, and we need more studies. And now it's just like, nah, like nobody's very excited about it.
I just think it's supportive care. managing problems, managing the airway, managing oxygenation, ventilators. And if people are going to come around, they're going to come around if you support them and minimize ancillary problems. I think that's it. Really.
It's just like good hospital medicine.
Yeah.
What other things are different where you come from versus this?
I mean, as far as ventilation is concerned, the protocols that we were working with out on the Long Island hospitals that I'm used to have a contraindication for things like BiPAP, CPAP, nebulizers. So these machines that are not intubation and ventilation, that's all the way down the tube, but rather non-invasive ventilation that's around the face with a mask. These things are aerolizing the virus, and so that's why there's a contraindication for it. I mean, it's a clear contraindication there. You go to, and then now here we're at Brooklyn, Kings County for like a week, and
everybody's on
BiPAP. 40% of our patients are on BiPAP, and it's just
that was very surprising.
But I think that also bespeaks the significance of institutional experience. I mean, and
what do you think about it now? Do you think BiPAP's okay, or you like that?
I mean, I think that
I get it. I feel like I understand why they do it.
Yeah, I mean, I also understand that it could spread infection a little more, but I think that what this all kind of bespeaks and underlines is that there's not a hard and fast treatment protocol. So there's a few things that if not many things, that we're still figuring out. And, it's not necessarily the case that one institution is right over the other. And that, I mean, I think BiPAP is good to bridge a patient before we intubate them. Sure. It makes sense mechanically. So
I think there's a it's, before coming here, I would have been like, no, because I talked to my friend who's an ICU doctor elsewhere, and it's like
Denver.
And then, did my own research. Don't do BiPAP because when you put the mask on the face and you're pushing air in and out, virus is going to go everywhere.
But then what about that one patient? Is that one patient being treated better though, because they're getting better ventilation, better air pressure, better? I mean,
but then like in practice, I feel like that's like on the books.
So you're helping the patient, but spreading the infection. I mean, that's a real.
But then there's also it's more complicated than that. Like the practical, like when we had that patient crash yesterday, it's an ordeal to intubate somebody.
Yeah. Especially,
you can take BiPAP and throw it on there and like save a life so much faster. And then they stay on the floor. The ICU is full. Yeah. And I feel like once you stick them on that vent, like it's even harder to get them off. Yeah. So I don't know. Like I question, if putting them on a vent is almost a little more of a death sentence when you do that. I mean, so yeah, there's a risk of infection, but like you said, like this might actually be a better treatment option.
But so they're not doing that.
And I would have said no before, but like seeing it, I was like, there's no way. Like there's just too many sick patients that need this. You can't intubate all of them.
Yeah. So I think that bespeaks a community and medical community still finding their way, finding their path into what is really good care. So I think it's still being figured out. I don't think it's defined as
what's this thing been around? 2 months, if that?
Yeah. And then I think, like you said, it's the patients are sicker than the flu. I mean, I don't want to be an alarmist, but we've seen some sick patients.
So like they're coming out of the true like field hospital crisis system overwhelmed. Stuff they were telling us was 2 or 3 weeks ago. So this is like plateau, right? It had things happen, things had peaked, and it's not this. It's like they peaked and it went down a little bit, and then it's like this.
Yeah. Very busy. I mean, wow. A ton of the patients in the hospital are COVID positive. I mean, that's all you have to say.
I think like number one, like probably like it's county. People are sicker to begin with. 2, they're going to have sicker people on the floor than, for example, the small community hospitals I work at, where Granny's fine, she's got a UTI and a fever, and she's on the floor, and that's about it. Like here, it's like they were just extubated.
Right.
They're on dialysis. They still are barely hanging on respiratory ones. Their blood sugars are 400. They're, it's just like all of these problems. And so these are really probably step down patients normally, but because the hospital is still full, they end up on the floor and pretty sick. I think like one of the first days we got there, like seeing how sick and how like active so many problems were for these guys, I was like, oh wow, that's a little sicker than I anticipated. I think in my mind I was like, okay, they got corona, they have low oxygen, respiratory failure, and we're just putting them on whatever for their lungs, and that's about it. I didn't realize it was like it's dialysis,
renal failure. A lot of these patients are developing renal failure.
It's dialysis, it's other clots, it's like it's subsequent bacterial infections like pneumonia, UTIs afterwards, and then all these hospital complications. And then it just gets so
complicated.
It was complicated.
Yeah. So
I think I was thinking about this PPE stuff.
Yeah. So yeah, what are your thoughts like before and after? I mean, there was like outside we wore an inside jumpsuit, and we wore like outside robes on rounds. But I mean, it got a little nasty in there, did it not?
The conversation in the meeting was that the doctors and nurses were all pissed that there's not enough stuff. I didn't feel like we were neglected. Yeah. I know it's not as
bad. It's also, I don't know what it was like 3 weeks ago either.
Yeah, maybe by now we got here and like that
some
wave
resupply.
Yeah. The supply thing wasn't bad. But like that said, like I thought it was going to be like, the infection police were going to be running the show. And
I thought so too, when we were doing all that like stuff to credential for the whole thing and all the modules and stuff. What I came to realize, at least by the first or second day, was we were at Kings County. That's a county hospital. I trained at Jacoby in the Bronx. It's the same thing. The residents rule the floors. I mean, it's just the wild, wild west. There's, it's not this police to that police, the Jaco police, the fashion police. They're not there. So you got to do good, but there's.
Nobody cared. Like it's like here's the stuff. You protect yourself when you go into rooms and take care of yourself. There was no infection police anywhere.
No, because I think that's the real story. I mean, you're talking about Kings County, Brooklyn. It's one of the epicenters. So.
Where the ERs that I work in, like everybody's in California.
Right.
Ironically, it's not even there, and everybody freaks out about every little thing.
And then here you're in the epicenter.
Like, this is what's so funny. They're like, holy shit, we're gonna test that guy. This guy over here might have.
Yeah, we have 12 patients
in full PPE
on our service.
We're gonna swab them. Yeah, and that's a really high risk.
I did an echocardiogram on like 3 patients COVID positive, and trust me, we got to know each other well.
And so like this one is. There's COVID up and down everything. And like today, I was in the ICU today with the fellow, and I had my mask on, and we had a full conversation.
Yeah, he had nothing. Because it's like, what? After a while.
It's like at this point, it's like, shit, you've totally been exposed. So
much, yeah.
That and this part, like, actually, this made me feel more, maybe it's a false sense of security that everybody that's working there is like, they're not afraid of it. It's not that big of a deal.
Well, yes.
Maybe that is
but
false sense of security.
No, I mean,
this is just like, it's not that big of a thing.
I mean, everybody that we're basically working with is relatively young and healthy. Think of all the residents and the people that we work with.
Right.
I don't mean to be someone that's.
So let me ask you the question.
Yeah.
Did you see many young and healthy people really sick from this? Like, who are the ones that are in the hospital with corona?
I mean, look. I think that being a realist at a point like this is very important because there's a lot of issues at hand, and that any life is important. But I do have to say that by and large, the patients that I saw that were sick with COVID, critically sick, dying sick, were very elderly and with many comorbidities.
It was both.
Yeah, I mean, honestly, half of them are patients from a nursing home that are not even mentally aware. I mean, think about that. Someone's not even verbal, and that's a lot of the patients with COVID, things like that.
I mean, I had one patient who was 20-something with no medical stuff. The next one was like a 40-year-old dude but he was diabetic. He had enough diabetes.
Yeah.
But it's not like I had a 60 or 70-year-old woman that was in great health. Yeah. Like everybody, it was like 70, 300 pounds, bad diabetes. Most of it was both. It was sick and it was old, which doesn't mean, it just means like, I think what it means is the younger and healthier you are, the less you should be freaked out about this for yourself.
100%.
So it isn't that surprising in that sense. And this is like a message to kind of counter some of the media stuff, which is like sensational. It's like, this is the viral apocalypse. Fucking kill everybody. No, it's not. Like, it is scary. We need to take it seriously. We do need to do the appropriate things so that people don't die. But all the anxiety about, God, I'm 32 and healthy. Like, no, it's not proud. It's just not.
I haven't seen that.
Yeah.
I have one young female, a Latin female who's 43. She's required high flow nasal cannula, so step up in oxygen. But she's getting better. She never needs to be intubated. She never went to the ICU. She just has a prolonged course. But, moderate to severe disease, I wouldn't call it critical. So, no, I don't even, I think she's the worst I got, and I got on my eye on her the most.
Yeah.
She's someone you don't want to let go that way. So, but no, is she going that way? No, she's getting better. So I can't say really one, somebody that's surprisingly young and healthy that has COVID that's dying from it. I haven't seen one of those.
Did you guys have a lot of folks that were just like very poor prognosis dying?
I mean, from the start, you get these transfers from nursing homes or whatever. I mean, it's a lot of just that.
I feel like we had a few people that it was nice to see, like day to day, they really got better. Like stuff got better, kidneys got better, they perked up, they were coming off oxygen. Like there were people that really did recover, and I was like, this is great. There's someone that got stuck, like we were talking, like stuck on needing 2 liters of oxygen or 4 liters of oxygen, they couldn't come off of it, and they're still stuck in the hospital.
Yeah,
can't send them home with O2. They can't go to a nursing home or a SNF.
So there's a big O2 shortage. So no one's going home with O2 tanks now.
Yeah,
it's a big deal because you got patients you get discharged otherwise, but there's no O2 tanks to send them home with. I have a patient like that of mine.
Yeah,
she's like only 50, but she's got some comorbidities like diabetes, and she's on 1 liter. All she needs is 1 liter, like the smallest setting on nasal cannula oxygen, and she's okay. You take her down to 0, she starts desatting when you walk her around.
Yeah, it's crazy, right?
It's crazy. And then she wants to go home. She's got psych issues. She's bipolar. She's getting upset. And I understand she wants to go home. She's not comfortable here in the hospital, but there's no oxygen to send her home with. She needs it right now. So you hope that she gets better soon. But she's getting agitated and she has psych issues. It's a difficult situation.
Yeah, we come in. I work in the ER, right? That's like the beginning of the game. That's like the kickoff.
Yeah.
And then the ICU, a lot of these people go through the ICU. We get them after. And when we get them there, you see a different side of their hospital course where there's a whole lot of things at play, like this, or it's like, okay, they're better, but now they can't walk because they've been in a bed for 3 weeks and they got a rehab.
Yeah.
Or they're getting better from corona, but they've been in the hospital so long, they just got a hospital infection of pneumonia or a urine infection because they got a catheter, or their dialysis catheter clogs, and you're managing all of these complications and kind of along the line of where this lady's sick of being in the hospital, she wants to get out, but this is like part of
the whole epidemic.
It's part of taking the ball and getting it all the way to the end zone.
Yeah.
You've got to get through all of these things and manage all of this hospital stuff. That's like part of the game. I think I forgot that. I mean, this was
it needs to be done before they go home.
And it's complicated too. Like all of these social issues make it complicated with homelessness. Did you guys have? Did you get into a lot of end of life stuff?
Yeah,
Code status.
Yeah, absolutely.
Families.
That's definitely
Keeping people alive that are suffering and gonna die.
Yeah, for sure. So
I keep coming back to that. They just had really bad and it's really sad. And I just feel like this patient is dying, clearly dying, you know, in days. And the family is not ready for her to go. And it seems clear to me that it's about families, loss and grievance is going to be bad. It's going to be hurt. It's going to hurt. But she's not going to live. All we're doing is prolonging her. Literally, she's suffering. She's sitting there, laying in the bed, miserable, can't eat, pain. Like we're treating her pain and we're taking care of her best we can. But she's just suffering. And we had a few of them like that. That's hard.
I have a few like that as well. It's fact. It's reality.
I don't like it.
Well, I mean, it's like this is what the nature of all of this is.
This is modern medicine. It's like keeping bodies alive.
Yeah, I mean,
people suffering.
I think a lot of resources are wasted there.
Forget resources. It's the pain, the baggage. I just free those suffering souls.
Well,
you know,
absolutely.
I thought the residents were good.
Yeah, they're good. Downstate residents, yeah, it's a good program.
I thought they were
I thought they were very good.
I thought they were
Yeah, absolutely.
Did
Made my job easy.
Yeah, did you like being an attending?
Yeah.
It's kind of fun. We did some cool stuff. We did some good teaching.
Yeah.
Some cases.
Yeah. But they had everything sorted. There wasn't too much I had to do. They were good.
Was this a good? I mean, this was your vacation.
Yeah.
This guy gets. Maybe you can see my fingers. He gets 4 weeks of vacation a year. He spent a week of vacation making no money for free at the county.
Yeah.
Taking care of corona patients.
I was supposed to go to Buenos Aires. I was.
You went to Buenos Aires,
Brooklyn.
Brooklyn.
I was supposed to go to Buenos Aires for this vacation that I had scheduled for a few months. But when I realized I wasn't going to go anywhere, and then when things heated up with the COVID, I figured this would be a good experience. And it would be a week that I would be more grateful when down like this than just spending on some vacation.
Was it a good week? Was it worthwhile? Were you glad you did it?
I have no doubts, 100%.
Why? Was it mean to you?
Just to be able to be a part of this whole COVID thing and the response in New York, here in my city, is great to be involved and, just to be involved with it all. That's good, number one. And two, the setup was good. I mean, we got to see some good COVID medicine as just objective physicians. We get to see firsthand this epidemic of our generation, this pandemic almost, or for sure pandemic actually, and learn about it and be involved with it on a historical level, traditional level, on a physiological level, just getting to understand it more. The residents that we worked with, and then the people that we helped, and then to see the reality of it, to have a sense of what's going on in your community. How great of a way to have a sense of what's going on in your community if you can be a volunteer physician at a COVID hospital and check it out. We did that. So, definitely life experience, 1 out of 10 of 10, of course. So, do you remember Tahiti or Hawaii with fond memories? Sure. Buenos Aires, I'm sure. Maybe one day I will. But in 3 weeks from now, when I look back on this, it's only going to heart my soul. It's only going to increase my resolve and make me think that I've seen things, and an appreciation for this whole experience. So no regrets, and then tomorrow's day 7 out of 7.
Tomorrow's the last day.
Yeah, tomorrow's the last day.
I think I think this thing is. I mean, it's. You're part of the team. You're a foot soldier in the battle. Like you're in the front line. That was the trench, man. We dug into that shit for a week.
Yeah.
And put in some good service and contributed. And,
Yeah. We're
part of that thing. And there's something about that kind of service for the tribe, for the nation, for New York has such it's got significance and symbolism for the U.S. and the world. Of course, it's being a part of something greater than yourself. Like a big movement isn't the thing, battle, big thing, and by being a part of it, you kind of feel significant, special, and this thing will stay with us forever. We did that, at that time. We could have sat here for the whole week and done, farted around and done whatever you wanted. I didn't have to come out
watch
here.
Westworld.
Could have watched Netflix all day long for 7 days.
Yeah.
I could have stayed in California and done whatever. But nobody will ever be able to take this away from us that we did this, and contributed, and kind of carried that with us. Hopefully we made a difference and gave this system a little relief.
Yeah, I think we did. You could see functionally how that happened.
Are you worried at all about getting it yourself?
Getting it myself? Yeah, I'm worried that if I get it, I won't be able to show up for work next week. That's what
I feel
worried.
like you've had enough exposure to that.
I mean, I was.
I got that antibody test today. I
we got it.
I don't know the result yet.
When the results come back.
Well, they said a few hours. I checked it.
So tomorrow we'll know.
Well, I think who knows how long it'll be, but I have computer access to my own little lab thing, so I should get that result.
Okay. Okay.
If you get it, you can donate plasma for study. I don't know. That's kind of cool.
Yeah, if that works.
I think initially I was having these delusional anxieties of grandeur where I was going to come out here, get corona, and die.
Oh yeah.
Yeah.
I think it's pretty unlikely.
A little bit.
Okay.
I thought about it a little bit.
Martyr?
Well, I've talked to this. There was this because I haven't seen a ton of it in California. I talked to this one ER colleague of mine that worked at Cedars, and she's like, "Have you seen this? You're male. It's getting young people." And I said, "What?
That's not what we've seen.
What better?" This is good. This is actually what I said to her. I said, "What better way to die than by serving a cause like this? You want to talk about it because we're all gonna die. What a way to go! That kind of thing. You voluntarily put yourself out there, you serve, and you die, saving people's lives.
Okay.
There's no better way to go. There's no better way to go." And she's like, "You're not thinking straight. There's something wrong with your head." And so she kind of put it in my head. I was like, maybe I should be afraid of getting sick a little bit.
No, I was just afraid of missing the work next week. I mean,
I was about to call my dad and write my obituary.
Yeah, no, I don't.
You have a daughter. You're not thinking right.
Yeah.
No, I'm like, I think I'm fine. I'm not really worried about it.
I feel like we were elbow deep in it this week.
No. So you just I was telling a friend of mine that I was going to go there. I was like, part of me was like, I want to get this thing. I'm going to go there and I'm just going to pull off an event. And I'm just going to suck on an event, right? And she's like, yeah, that's maybe just, do the job and you're probably going to be exposed anyway.
Yeah, I think that's what happened.
We were good about PPE the whole time. Protected, there's nothing.
Well, we just did the basics,
We wore appropriately. This is a weird disease.
Yeah, I mean it's very contagious, and some people get very sick with it.
We think this stuff is like DIC that causes all this stuff.
Not everything, but it seems like there's like serious DIC stuff going on.
Kidney failure, PEs, people with drought.
I mean, just the number of the D-dimer is so high.
Yeah, that's crazy.
They're ridiculously high.
It's a fascinating disease.
And then the kidney stuff, like they really are having acute renal failure, some of them. So thromboembolic, yeah. And then I haven't seen a ton of PEs, but I mean people have seen that. But I've seen a good amount of renal failure, like
a lot of that.
Like go to creatinine from 1 to 4.
They're
like not subtle.
ICU guy that I was talking to.
Yeah, he seemed like he saw some stuff.
Yeah, he was saying this is after you left. A lot of people were dying because they couldn't do dialysis. That was why
their blood pressure was too low? Or?
No, because they didn't have enough capacity.
Oh, because they actually couldn't get the
all the
machine
dialysis nurses got sick.
What?
And so they only had one dialysis nurse, and that would take 2 hours per patient. And they were only able to dialyze a limited amount of patients, and they weren't able to do dialysis.
Right, that's not America's stuff. I mean, that's third world problems. That needs to be figured out. That's unacceptable.
It has been now.
And I know now it is, but that's unacceptable. Like, there's machines there. Someone should not die in the United States of America because they can't get dialysis.
He was telling me dialysis limitations was a big part of the problem. I mean, he also said, like, normally an ICU nurse is on 1-to-1 with a patient, one nurse, one patient. Maybe one nurse has 2 patients. They were like one nurse taking care of 7 patients, and they were sick. Doctors were taking care of 30, 35 patients, which is insane. That's how the whole thing got out of control. But he was saying a lot of it was dialysis.
Yeah, that's too bad. I mean, that needs to be.
It's interesting, right? But that complication.
That shouldn't happen, but that's not a thing I think that should happen in the first world country.
That a lot of shit should happen.
Yeah.
What are your takeaways from this?
My takeaways are that it's definitely very prevalent. We've seen a lot of patients with COVID, so it's prevalent. It's there.
What do you tell people and your patients?
People what?
What do you tell people and your patients? Don't get it. Be smart.
Well, look, I mean, I think that you should be smart and safe, but I don't think being neurotic and anxious helps anything.
Right.
I think that harms things.
Too much. Don't be OCD.
So do the basics. If you're higher risk, like above 65, 70 of comorbidities, yeah, I think you should hunker down a lot more. I think that in general, people should be doing the basics, masks and things like that. But not worrying all the time. I don't think that helps anything.
Is this thing like the flu?
I mean, it's like it, but it's worse, it seems like, right?
So much worse.
I mean when have chest x-rays, they're all like those COVID chest x-rays.
It's like sometimes you get pneumonia after the flu. That's true. But
when have you ever seen... They're just like this similar. They're the same.
When have you ever seen like kidney failure?
ARDS?
PE?
ARDS?
Yeah. Like when have you seen these complicated? This thing is not the flu.
Yeah.
It's a virus. There's similarities, but this
is
severe and way worse. I don't think I appreciated how many people have more than lung problems with this until this.
Yeah, the renal failure. Yeah, that's bad.
Other organs failing.
Yeah. Problems. Once you have more than one organ system failing, it's bad news.
The ICU guy was telling me, like, if somebody comes in on dialysis with kidney failure and they end up intubated, they're not going to survive.
Yeah, he wasn't he saying they got like acutely hypoxic out of nowhere also? Like they would desat to 70 and they went What's going on?
Like our guy, that was yesterday. That was that
Yeah, but
guy.
what's going on? Like they have a thromboembolism at that moment?
I don't think it's like an acute PE. It just sounds like it's like this. I don't know what the mechanism of the hypoxia is, but whether it's this cytokine, some kind of immune reaction, and then you're not oxygenating anymore. I don't know. It just seems to like go bam. It seems to be like one of these cascades that whatever triggers the start of it, you know, whether it's like we have a clotting cascade, we have all these things. I mean, I'm kind of allergic to it. It's not allergic, but it's fast. It's crazy fast.
Yeah.
It's unique. There's part of me that feels kind of like, you know, the nerd doctor in me really likes the pathology. It's fascinating.
I don't think there's anything wrong with that.
It feels a little bit
morbid
is the word.
No, I mean, it's there. You didn't create it. So you might as well learn from it.
Studying.
That's all right. That's how you learn. You know. So maybe you have a patient a little bit down the road that has a lot of that stuff, but not all that stuff. So they're salvageable. And because you saw someone that was not salvageable, you can help the next patient that, you know, is 80% as bad, but there's a chance.
Yeah.
You know? So you learn from it and apply it going forward.
I think beforehand I would not have. I would have used blood thinners and anticoagulation if somebody had a DVT or PE. Now
they're doing it like prophylactically.
Yeah, or with D-dimer or whatever. I would be more aggressive.
You will be going forward based on the D-dimer level. Like that's how they're doing it all up and down Kings County.
Yeah.
And
I would.
Yeah, I would too. Like, so I think the D-dimer they're using is like 1,000 or 2,000. If it's above that, they're giving treatment dose anticoagulation.
Is that what it was? 2,000? I thought it was 3. I forget what the number
was. My people quoted me, but
they had it
like 2 and 3 or 1 and 2. Wasn't hard and fast.
Yeah.
Like some people were using 2 and some people using higher. But you know, if you have a patient that's only like a moderate risk for bleeding,
Do you have any favorite patients? I had a couple of favorite ones. I like that guy we did the echo on. He was kind of a character.
Yeah.
I liked that dude. Stubborn guy. Didn't go to doctors.
Right.
It's usually my kind of guy.
Yeah. Yeah. I mean, yeah, I like to, you know, I have a propensity towards patients that are salvageable. So if I see that someone has a chance of going home and, you know, not just necessarily to a nursing home or to hospice, but
there's a real quality of life.
That there's a real quality of life that you can intervene on and restore, help to restore. Yeah, those are the ones that that stick out in my mind.
It's like the most meaningful recovery.
So that's what I, you know, kind of set my sights on.
Yeah, for sure.
Yeah. So I kind of looked through the list, and out of a list of like 15 today, honestly, there was like 2 or 3 of those patients. So
I would say there's a few. I agree.
So 2 or 3 that I felt like they have a chance of getting over this and just going home, back to normal life.
Yeah.
So those are the ones I identified as the just priority, the goal. Like
treatment, basic triage.
Get them, you know, they have a real chance. They have a real shot. Get them home, you know, with the best shot. So I have a few patients like that. Those are the ones I hone in on.
You know what I thought a lot about this week is how difficult it is that there's no visitors, especially
for
the dying.
I've been dealing with that too for a while here in New York, on Long Island, here in Brooklyn, and it's tough. I have had some patients from my practice die, at least 3 or 4 or 5 of them, and I was making phone calls nightly to the daughters, to the this and that, and I think that's what you have to do in a time like this. You have to fill them in. I saw them today. You didn't see them today. I saw them today. Even if it's a 10 or 15-minute conversation at night, and you know, I set my alarm on my iPhone. After I'm done running, I'm going to call them. And even if it's a quick conversation, because they can't see them at all, it must be so difficult. So, yeah, I think that's something else.
It's terrible. I mean, it's difficult for the family. It's difficult for the patient. That isolation it's a.
I feel for that. I really do. But on the other hand, if you're trying to stop the spread of an infectious, contagious disease, then it makes a ton of sense.
It does.
At hospitals,
but
we
gotta figure out a way to be safe. And I mean, at least when they're dying, there's got to be a way. Get somebody in there. God damn. I just that stuff. It's hard enough when somebody dies and the family's there, holding their hands, talking to them. Part of it, that's hard. But it's just. I mean, it's heartbreaking for both of them.
Yeah, it's tough.
It's bad stuff.
Yeah,
I was like, and I think it makes a difference for them to video, to see them with their own eyes.
I think that we've seen a lot of
with that. I was talking about this the other day where I was like, if there's any way that people could volunteer and put all the garb on and just take an iPad and call families and just video with them. I mean,
yeah.
I also think there should be there's got to be some kind of way to have minimal visitation that limits exposure. Let's apply our brains to that.
Well, I think that may be in the next phase, but for now, I understand. You just limit the amount, like visitors, like bar none, all of them. You really limit a lot of infectious spread. No visitors can come to the hospital. That's
sure, but especially, I mean, for the people who are surviving, they're going to be fine. They can call everybody and whatever. There's that, but you know what I'm saying.
For people who are dying.
These people that are dying.
To see their families. So yeah, we get them up there at the end. I've gotten patients' families.
We did. This week we did. We got them up there when they were in it. It's intense, man.
Yeah.
Death.
It's part of life.
It is a part of life. I got a big question for you.
Guaranteed.
I haven't even asked you this question this week.
Yeah.
Why did we die?
Why?
Yeah.
Why do we die? I guess our cycle is done. Like hopefully we got accomplished what we came here to accomplish.
You know what I mean? Big question.
Why?
I mean, living forever actually, if you really think about it, sounds terrible.
But there sounds like from the movies I've seen with vampires and the Highlander, there definitely seems like there's drawbacks. Yes, I've heard of that. All your friends and family die, you watch them. Yeah, I heard that.
It's like if you live, let's say everybody lives forever. You all live forever. Like there's no motivation to do anything. It's like, well, I don't know.
Yeah, maybe not.
You didn't deteriorate. Like you just like, no, I'm just gonna
chill for
Netflix all day a day. It doesn't matter.
All day, 370 years.
I don't know. Yeah. But it's still fascinating.
Death.
Go on.
It's probably coming.
Your consciousness. What the?
Well, you don't know what happens after that.
I don't know.
I'm a big believer in the.
You think there's something?
When it comes to this is I'll leave it kind of like a bottom line. My bottom line is I'm a believer in the first law of thermodynamics.
Energy. The
energy can neither be created nor destroyed. Transfer, but
goes
neither created. So once the Big Bang happened, the first law of thermodynamics dictates that energy after that point can neither be created, there's nothing new on the block, nothing new under the sun, or destroyed, or truly dead. Do we see this like plant, animal, fertilizer, vegetation? You know those cycles from biology books. I mean, how do we know that doesn't apply to a higher level, more metaphysical level? But I don't know much beyond that.
There's on Ash Wednesday, the Catholic beginning of Lent, you get these ashes, right?
Yeah.
And sometimes they would say ashes to ashes, dust to dust, or you are dust, and unto dust you
You
shall
will
return.
return.
You shall return. And it's the cycle of
So,
life. Like
yeah.
we eat things out of that literally come
Ground,
from dirt, and then
there's
become
fertilizer,
ourselves.
Ourselves.
And then we go back to the ground,
Yeah.
decompose
Yeah.
our matter.
I
It
mean,
does recycle like that.
just
But then
think
it's
about
the,
that.
but then there's that like consciousness soul thing.
Yeah, what happens to that?
Yeah, well, I've been thinking a lot, like watching these patients sit there and like they're coming, and so many people are dying, and I'm sitting there, I'm like, why do we die? Why do we suffer? Why?
Well, I don't think suffering needs to be synonymous with dying. So I think that's something that I would identify. Death does not have to be this painful process, especially if a life I feel like was lived well, with good nutrition and exercise and well-being and productivity and positivity and purpose, and love, then you should live a good life. And then you should maybe transition to the next phase, which is maybe sounding like it's after death. Doesn't have to be painful. I mean, why is it negative? Why is the default that it's negative? How do you know it's not like this great experience that comes next? I'm not saying it is, but you don't know. So why is the default that it's negative?
I mean, there's certainly fear that it's either not
the end.
Yeah, the end.
I know, but that's just that's conjecture. That's hypothesis. That's guessing. There's no proof of that. There's no proof.
We don't know.
We have no idea.
And I think the other part of why it's often negative is because
we're leaving those people are leaving us, but